So now, last but not least, certainly, we would listen to Dr. Tarique Huda from Bangladesh.
I would like to start by thanking the organizers of ANH Academy for supporting me to come here and present my work. Today I'm going to, I actually prefer to, sorry. Today I'm going to talk about some of our efforts that we tried in Bangladesh to improve food hygiene behavior. I am from ICDDRB, International Center for Diarrheal Disease Research in Bangladesh. It is a health research institution based in Dhaka, but tries to impact with their work globally. So I'm sure I don't have to convince this audience that undernutrition is a big concern for low-income countries, but also globally. There may be several possible causes of undernutrition. Some of the important causes include insufficient intake of nutritious food, but also poor food hygiene that could lead to repeated enteric infections and reduce nutrient uptake in the gut, leading to undernutrition. Although microbial contamination of food is an important cause of enteric diseases and also highly prevalent in low-income countries, but often this is not considered in nutrition programs. Consistent adoption of food hygiene practices could reduce microbial food contamination, but it is challenging to achieve. For example, in the context of Bangladesh, our surveys have shown that people know about hand washing, but when you go and observe their hand washing practices, the actual practice is rare. And it is also difficult to change hand washing behavior through large-scale programs. So we aimed to design, implement, and evaluate an innovative food hygiene behavior change intervention within a nutrition-sensitive intervention in rural Bangladesh. So today I'm going to present some findings from our process evaluation. So the main trial that is being conducted in Bangladesh is called FAARM, Food and Agricultural Approaches to Reducing Malnutrition. And the FAARM project is actually evaluating the impact of an enhanced homestead food production program being implemented by Helen Keller International. And this is being delivered to 1,300 young women and their children. And the reason they wanted to include young women so that they can capture the first 1,000 days of the children's life. So as I said before, our food hygiene intervention was added to this large trial to strengthen the FAARM interventions. So what we did was we adopted a behavior-centered approach that was piloted in Nepal by Dr. Om Prasad Gautam, and we adopted the approaches and modules in the Bangladesh context to implement it in a larger and slightly reduced intensity. The modules employed several emotional drivers like nurture, disgust, and pride that are found to be working at the context of Nepal. Our intervention also encouraged to change the setting of the household environment. So the behavior change scientists that we have been working with, they are saying you need to change the script in people's head, but also you need to change the setting where the behaviors occur. So we included several interactive, participatory fun activities like games, storytelling, and competitions. The intervention lasted for 8 months. We had 4 group events and 4 individual events delivered by trained female community food hygiene promoters. This is a picture of one of our intervention activity. So we helped the households to make it, to rearrange the kitchen so that the new behaviors can happen in the new setting. So you can see pictures of rearrangement before and after. These are also some pictures. So the first one is a picture of a disgust exercise. So using glow jump to sort of show that how the invisible germs can be in your hand and you don't see it. And the next one is actually a child life game. I'm not sure if it is visible, but basically there are, these ladies are using masks to play a role of a healthy and unhealthy child and how food hygiene practices could impact the children's later life. These are the 6 food and optimal feeding practices that we promoted through this food hygiene campaign. And as I've been saying that there are different activities. We also had 2 competitions. So we announced that at the end of the intervention period, there will be two competition, and winners will be given prize. First one was a clean kitchen competition, where the households had to show that the kitchen was clean when our food hygiene promoter visited. There was a hand washing station. They had separate area for animals, and also they had a rubbish in a covered container. So this was the first competition. And the second competition was that the caregivers had to maintain 5 out of the 6 food hygiene practices. So how did we assess these winners of the competition? So during the food hygiene intervention, the food hygiene promoters documented household attendance and women's practices of behaviors. We had 4 group events. Out of these 4 group events, the last 3 events, the food hygiene promoters observed these household practices, and a household would be considered either a clean kitchen or ideal family owner only if all the behaviors are practiced in all of the 3 observation time points. So this is the baseline characteristics of our study families. The important thing to note here is that in Bangladesh, majority is Muslim, but in this part, actually almost 30% are Hindu. And one of the important implications for the intervention was that the food hygiene practices are different, and also for the group events, we had to have several separate group events for the Muslim and Hindu families. And sometimes the Hindu families would not go to the Muslim families. And overall, there are, I think, on average 7 household members per household. So there was an important role of the mother-in-laws in the intervention participation. And most of the women actually had some sort of formal education. This is the most important slide I'm going to present. This is like the uptake and actually what happened is at least more than 70% of the families had high uptake. And only 40% of the household actually own the ideal family winner competition, and about 50% of the households own the clean kitchen competition. This is a slide just to show that within the different indicators that was aggregated for the clean kitchen indicators, presence of hand washing facility was lowest. And also within the food hygiene indicators, as you know, like different behaviors have different challenges. So here we have seen that cleaning utensils and washing hands had the lowest uptake. But then like food storage and food reheating food had better uptake. So this is showing the adjusted association between degrees of participation in the food hygiene intervention and winning a competition. So the women from households that had higher participation had higher possibility of becoming ideal family or clean kitchen winners. So to conclude, the intervention was well attended and accepted by the community. However, uptake of behaviors varied, suggesting that some behaviors were easier to adopt than others. Lack of facility for hand washing and cleaning utensils could have been a potential barrier. And people always say that Bangladesh is a delta and we have no shortage of water, but there is shortage of water in the kitchen of the women, and that was a big barrier for practicing these behaviors. So unfortunately, we do not have all the results from our observations, but hopefully in one of next conferences, I'll be able to share them. So this is a study team that was involved in the study, Heidelberg Institute of Global Health, Heidelberg, Germany, Helen Keller International, Bangladesh, and ICTDRP. The study was funded by the German Federal Ministry of Education and Research and Fiat Panis. And ICTDRP thanks its core donors for their ongoing support. Thank you so much.